comfortable with unknown. That should be the mantra we all should practice. But also at the same time, we need to see, and this is directed to my founder chairman, do we have systems in place? Do we have organizational flexibility and what I call tolerance in the society to allow for practical implementation of these marvelous scientific advances? How would we best enable a successful future focused on improving the cardiovascular health and lives of our patients? How do we deliver the value proposition we espouse and upon which we are ultimately going to be judged? So, we need to regain our footing. We need to demonstrate to our patients and to public and to students the highest standards of professionalism and competence. And so we need to learn the burden and responsibility of self-regulation. We can do better. Trust me, this university, this faculty, this esteemed gathering of intellectuals can do better what you're doing. And I'm so proud of the new cardiology department and the faculties. And I'm so proud that we got our DM course recognized, well permitted by NMC. And I have really high expectations. And once again, I think these kind of educational CMEs, and I'm very happy with the program put up by Dr. Pradeep Gupta and team today, especially the clinical scenarios, incidences. I think it's going to be a very interesting CME and something really new will be learned today. Thank you very much.
Thank you so much, ma'am, for the address. We invite respected Dr. Pradeep Gupta, sir, Head of Department Cardiac Sciences, to kindly brief us about today's event.
Sir, our founder chairman, Dr. Jyoti Bindal, our VC, heads of departments, faculty colleagues, dear PG students, ladies and gentlemen. At the outset, let me extend a very warm welcome to each and every one of you in our first CME. Department of Cardiovascular Sciences, as per the vision of our founder chairman, is providing services ranging from prevention to intervention, both cath-based and surgical, to rehabilitation. We are happy to share with all of you that we are getting a new heart command center which would be equipped with 2 state-of-art cath labs. Regarding the scientific program, it's a mix of case discussions and lectures. And the first presentation is from Department of Nuclear Medicine. And it is extremely important for our PGs because they are underexposed. So they would learn when and how to get the services of nuclear medicine department to benefit our patients. Then it is followed by a series of case discussions from the cardiology department, from the CTBS department, from pediatric cardiology and pediatric surgery, followed by 2 lectures from cardiology department. I am pretty sure at the end of CME, we all would be benefited and we would be able to manage our patients more efficiently. Thanks and welcome you all again.
Thank you so much, sir. Now we welcome Dr. Manish Bhagat, sir, and Dr. Gaurav Singh sir to come on the dais. We request you, sir, to commence the program.
Good morning, everyone. I agree with ma'am that we need to improve and we need to think out of the box. So here, I would like to call a man who is always trying to improve in the field of nuclear medicine, always thinking out of the box. I would like to call Professor Dr. Mahapatra sir. Sir, please come. Sir has graduated from SCB Medical College, Cuttack, and subsequently completed his postgraduate qualification from University of Delhi and went to Boston for higher education in 1982. After coming back to India, he worked in various hospitals and worked as a senior consultant and head of department in Seven Hills Hospitals, and now currently working as a head of the department at Aurobindo Hospital. Sir, over to you.
Thank you. Thank you, Honorable Chairman, Bhandari, Vice Chancellor, all the dignitaries, students. So for the next 30, 40 minutes, I will be talking about today the clinical nuclear cardiology role. But before that, since most of the students are there, they may not know what is nuclear medicine and everything. So after briefing that, and then I'll come to the my topic. So, so nuclear medicine in clinical practice. Yeah. So, what is nuclear medicine? It's a painless procedure. What we inject a radioisotope which has got a half-life, say about 6 hours, either by IV or oral or breathing device. So this radioactive material emits gamma rays and travels to the intended organ. Special gamma camera, that SPEC system. I worked with planar stationary gamma camera, then SPEC, then the PET system interface with computer records these radioactivity in the form of image and scan. So a highly sophisticated computer processes quantitatively various recorded data to diagnose and quantitate the extent of the disease process. So after we inject some radioisotope, then a patient may be asked to wait, or after the administration of the radioisotope, the waiting time varies from 15 minutes to few hours, and in exceptional case after 24 to 48 hours. This waiting time is necessary because the compounds, the radiolabeled compound which you inject, they go to the different target organs. So that requires certain time in accumulating the area of your body being studied. Apart from this, we also do a lot of dynamic scan like Maker's diverticular bleeding, like GI bleed scan, like renogram, DTPA scan. So other scans are there. So, so taking the scan in the picture. So the time when the comes, then we patient position under the special detector. Then number of different pictures or images are taken. These images may be seen on computer SPEC gamma camera and will preserve on the film for later study. Patient may breathe normally during the study. Here, it's the special gamma camera. What it does, when you inject a radioisotope, it emits gamma rays. The gamma rays is picked up by the gamma camera. That is why it is called gamma camera. So it doesn't produce any radiation. I'll come to the radiation part. It simply picks up signal from the radioactive compound. Even multiple pictures will be taken. You will not be exposed to any radiation at the risk level. These pictures make it possible to gather more diagnostic information. So what about after the test? You must be seeing that when they come to our department, nuclear medicine, we inject. So daily activities is generally not be affected. One can resume his or her official daily routines immediately after the test. Regarding medications for certain scans like cardiac and other things, certain drugs have to be stopped before the particular scan, such as renal, cardiac, and brain spec scan. So how safe are the nuclear medicine procedures as compared to CT and other modalities? So nuclear medicine procedures are safe as compared to other diagnostic tests as X-rays and CT scans, because a small amount of short-lived radioisotope, which has got a half-life of 6 hours, administered IV to the vein, which is quickly eliminated from the body, usually within hours, for which multiple IVPs are contraindicated than multiple isotope nuclear scan, particularly the renal scan or the scan. And what about, you must be thinking, what are the reactions? Does it produce any side effect? No. Adverse reactions are nil. Why? Why there is no adverse reaction? Because it's an inert compound. It doesn't react with the blood component like CT. You give contrast, then that's a live compound. So it's an inert compound. It doesn't require any, it doesn't have any side effects. So radioisotope does not interact with the blood component as compared to dye. So please do not say we inject dye, we inject radioisotope. Many referral come from many faculties that we inject dye. So which is being injected in, so dyes are injected in IVPs and X-ray and CT scan, etc. So what are the contraindications? So in nuclear medicine procedures, there is no contraindication except pregnancy. Except pregnancy, there is no contraindication. And you must be thinking in your mind, what are the radiations? So I'll just show you some slides. So in gamma camera, the physical half-life and photon energy, as I have told you, only 6 hours. The kinetics and location is half time. And then this is the way we inject, we position the gamma camera into dual head things. Then, and some of the effective dose received in nuclear imaging. Suppose you ask for a bone scan. So what is the millisievert? The 6.3. Parathyroid 3.8. Thyroid scan 1.2. Lung perfusion and VQ scan, that is ventilation perfusion scan 4.8. If you do a CT angiography for a pulmonary embolism, you get 13 millisievert as compared to 4.5. The radionuclide infection imaging 4.5. Hepatobiliary hydra scan 2.8. And also the myocardial perfusion spec. When you do a stress and rest, we get 9.3 millisievert for technetium standby and 11.4. And if you do only stress, it's about 5.8. So similarly, the radiations are much less millisievert as compared to other modalities. For example, say if you do a myocardial perfusion scan, so there is no contraindication at all. But if you do a MRI scan, then there are a lot of contraindication, like patient having devices, EGFR is more than 30. So all these contraindications are there, but here, as I have told you, contraindication nil, except the pregnancy. Then these are the cardiac FDG PET study. So you can see that the only sievert is rubidium agent 0.46. And these are all rubidium studies, but I'll show you the PET studies. So you can see here, now the FDG PET study 3.51 millisievert, much less as compared to other modalities. So practically the spec doses are usually dual isotope only used, primary myocardial infarction, congestive heart failure. So usual single isotope exposure is 8 millisievert, much less. So little bit of, I just would like to tell you about different scans. The radioisotopes are used. So nuclear medicine is a diagnostic part. We inject the radioisotope. Then therapeutic part, we would like to introduce very shortly high-dose radioiodine therapy, lutetium therapy, and other targeted therapy for various cancers. So these are the radioisotopes used: technetium, thallium, gallium, iodine-131, indium. So, and these are in vitro. When we started with radioimmunoassay. So that is called RIA. So there are all in vitro tests. So all scans has been named brain, HMPO, brain spec, thyroid, parathyroid, stress thallium, gated spect. So these are all hormone assays which you do by RIA, radioimmunoassay. Here the liver scans and all scans, PET scans, all scans are done over here. Now, since there's a discussion in the latter part of the day, I just would like to quickly talk about diagnosis and follow-up of acute pulmonary imaging, embolism. So you see here, as you all know, acute pulmonary embolism is a life-threatening condition that requires prompt diagnosis and subsequent treatment planning. So if you see that in the night, patient complains of pain and the ECGs are normal. So you'd like to say, am I dealing with a pulmonary embolism case? So you may call us, even in the night also you can come and do a pulmonary embolism perfusion scan. If the perfusion scan, both lobes are normal perfusion, you can rule out 100% there is no perfusion, no pulmonary embolism. So if it is there, then you can start a thrombolytic therapy. After 3 weeks, I'll show you, you can repeat and see the perfusion has come back to normal. So here is the most some embolism fails to, suppose some of the embolism they fails to do with the thrombolytic therapy, that is called chronic thromboembolic pulmonary hypertension. So in that case, what I'll do, chronic thromboembolism, CTEPH, secondary to acute thromboembolism, the only potentially curable form of pulmonary hypertension. Though echocardiography is the recommended first diagnostic step because the peak velocity of tricuspid valve regurgitation, calculation of heavy pressure gradient and other. But however, these findings may be absent in the early stage of disease, and echo has been shown to miss pulmonary hypertension as compared to CTEPH in 10 to 31% cases. So ventilation perfusion scintigraphy is the imaging methodology of choice to exclude CTPH. So if you see SPECT, VQ scanning versus MDCT, MDCT is very good for all big arteries, but in peripheral arteries, the SPECT perfusion ventilation scan is much more better than MDCT. Then comes the invasive angiography, as you know. So this is a normal lung perfusion scan, which you can see the right lobe and the left lobe and everything is normal. Before I show you to an abnormal scan. So this is a normal perfusion scan with macro aggregated albumin radioisotope, technetium label. So here you can see beautiful, see here, see the upper lobe and the middle lobe of the right side showing a technetium perfusion scan showing a perfusion deficit. Here it is the technetium BTP aerosol, the ventilation. So ventilation is normal. So this is typical of mismatch ventilation perfusion scan. So you can start immediately that thrombolytic therapy, and how soon you can repeat whether this has come back to normal. Please remember 3 weeks after you can repeat that and see that the things will come back to normal, or it may go to chronic thromboembolism. So now my topic for which I have been invited by the cardiology department or cardiovascular sciences to give my, probably this is the first talk in SEMS about the nuclear cardiology. It's a vast subject. I cannot complete all the things in 20-30 minutes. So some of the aspects I'll have to tell you. And nuclear medicine is a very vast subject with the PIAT and everything. So it is very difficult to finish in short time. So current concepts I'll tell you. Beautiful indication, beautiful follow-up. If you don't know, please try to remember. And after my talk, there's a 10 minutes question answer. Please ask me any other question, faculties or students, anywhere, any doubt. Don't feel bad. Don't feel shy. I am there to ask or to answer all your questions. Because I have spent 40 years of my nuclear cardiology practice, and I'm the pioneer in establishing the concept of nuclear cardiology in India in Hinduja Hospital. I worked in Hinduja Hospital Chief. I worked in Nilavati Hospital Chief. I worked in Saifi Hospital, South Bombay Chief. I worked also in Seven Hills Hospital as a chief. So don't feel shy. Please ask me questions. So, okay, fine. Since this is your Aurobindo University where I have joined here in the month of September. So why nuclear cardiac imaging? There are so many angiography, stress test, echo, MRI, CT. So why? This is a non-invasive physiologic stress perfusion function It has got an improved sensitivity and specificity. What it gives? Diagnosis, presence and severity of the disease, prognosis, short and long term, treatment effects, then ultimately improve patient management. These are the why nuclear cardiac imaging is required, and non-invasive, non-painful, no side effects. So what are the radioisotopes available? Thallium-201, we do over here technetium system-wise in SEMS, then dual isotope, then with myocardial viability, F18, FDG with PET imaging. This is not only nuclear cardiac. There are lots of non-coronary disease, inflammations, lot of infiltrated disease. I'll be coming one after another. And these are the gated SPECT. I started with a planar scan in Hinduja Hospital in 80s. At that time, SPECT gamma camera was not there in 88. So after that, the SPECT perfusion scan came, and then the PET came. So these are the radioisotopes which has been mentioned here. So as I told you just now, I started with planar myocardial scintigraphy. There, I didn't have the rotating gamma camera, stationary gamma cameras, fixed. You have to take only images on the heart. So let's see. So what is the basic difference between a thallium or a system-wide perfusion imaging and coronary angiography? So this gives, one gives the physiology, one gives the anatomy. So physiology means regional myocardial perfusion to differentiate ischemia and infected zone. Just I'll give an example. Suppose a patient, you are doing duty in a lot of emergency areas here in SEMS. Suppose the patient comes with chest pain and the ECG is equivocal. You do only one scan that can diagnose. That is, you do a resting myocardial perfusion scan. Even you can come in night and do a resting myocardial perfusion scan. If something is normal, that means you don't have any cardiac problems. Troponin, CPD, all these parameters, that comes very late. But we can rule out patient having chest pain. I told you, you can do a long perfusion scan, or you can do a resting myocardial perfusion that can rule out any ongoing acute events going on inside the heart. So let's see. As you saw, this shows the arteriography. There is a D1 lesion, there is a complete lesion here, and there is a complete perfusion defect on the anteroseptal wall. This is physiology, this is anatomy. So now you see one case, I show you, arteriography, 95% lesion in the mid-LAD. See, the mid-LAD, pre-angioplasty, before angioplasty. Because if you do 95, 100% before doing a myocardial perfusion scan, you may land up in doing a scar and doing a angioplasty, which is called a cosmetic angioplasty, which I have seen many cases in Mumbai during my stay of 40 years. So here you are getting a lesion here. Let's see how it looks in planar scintigraphy. See here, clear curly, there is a perfusion defect, and the delayed image, there is a reversibility total. See here, anteroseptal defect. So these patients should be subjected to angioplasty. Let's see how angioplasty looks. See, now the angioplasty has been done here, and now the perfusion is normal. This is called the post-angioplasty evaluation. Now the era went ahead. Then I entered into SPECT myocardial perfusion scan. The first SPECT machine, gamma camera, I had in Lilavati Hospital, Mumbai, where I started the department. So here, now you can see the dual head SPECT. The same, you have got fantastic equipment here. I mean, I am thankful to Dr. Bhandari. He has given the same. This is called the Simia dual head SPECT gamma camera, the same model which we have got. This is the Lilavati Hospital. So same we have got here. So before I go to the heart, how you do interpretation, the three views, that is coronal, sagittal, and slice. So you can see short axis, coronal cord, then the vertical long axis, then the horizontal long axis. So these are the areas which I want to tell to the students. We prepare the slices on the computer to see the perfusion status. Then here you can see here, anterior septal lateral, just a minute, anterior septal lateral inferior. These are the areas where I can see See here, you can see that there is a perfusion defect in the inferior wall, and in the delayed picture, it is reversible. You can see here, the inferior wall. So there is a RCA, probably RCA lesion, which is showing reversibility. So this is one case I want to show. So these are the radioisotope, technetium label cestamide. We are using here either tetrophosphine. They are a similar compound. So now coming to the various clinical applications, how it works. Let's see. What you will do? I want to ask you. Suppose a patient comes to you or goes to the medicine department. As Dr. Jhasa बैठे, high risk patients having a strong family history, hyperlipidemia, chronic smokers, diabetes mellitus, hypertension. So in this case, do you want to subject the patient for an invasive coronary angiography, or you will do a non-invasive stress myocardial perfusion scan, so that we can, if that is positive, please go ahead, do angioplasty intervention study. So you can see over here. So I'll show you one. Similarly, there are equivocal or false positive treadmill stress test, positive equivocal, mild acute depression. So these are the indications where you can do a stress myocardial perfusion scan. So female patients, best is stress myocardial perfusion scan, not achieving good effort tolerance in treadmill alone. Then the pre-angioplasty evaluation, all these things, CABG evaluation. Then follow patients of CABG, post-angioplasty, multiple coronary artery involvement in assessing the viable myocardium or hibernating or stunned myocardium. So these are the different collateral, these are the different indications. So first case, suspected CAD patient having a strong family history, ISD, uncontrolled diabetes mellitus. Do these patients need an invasive test like coronary angiography, or a non-invasive like stress thallium or cestamide myocardial perfusion scan? Answer: stress thallium or cestamide myocardial perfusion scan is mandatory as the frontline investigation to diagnose underlying CAD. How? See here. See here. There is a lateral wall perfusion defect on the stress MPI, which totally reversible. Here you can say anterior, apical, and inferior, it is totally reversible. The lateral wall reversible. So this patient can be subjected for angiography, followed by angioplasty or bypass, whatever, depending on the lesion, where the lesion is sitting over in the coronary artery. So equivocal or false positive treadmill stress test. So आपने stress test किया, but there is some equivocal results. You are not confirmed whether the patient has got coronary DG or induced ischemia or not. So then you subject the patient to our stress therapy. See here, this is called a equivocal false positive treadmill stress test. Same patient we subjected to perfusion scan. So here you say it is normal scan. No, normal scan. There is no perfusion defect at all, though treadmill stress, because treadmill stress has got its limitation, 66 to 72% sensitivity sensitivity as compared to our myocardial perfusion scan over 90%. So the normal. So now I'll show you a very interesting case. Normal stress test. See, normal stress test is normal. Patient is very comfortably did 6, 7, 8 minutes, no HCT changes. Same patient, but abnormal gated spec myocardial perfusion scan. See here. So this is normal. Patient attend here 151. There is no HCT depression. Just see the same patient, Arun Ghole. See here. See, Arun Ghole. Are you seeing anything? Here, the perfusion defect at the anterior septal wall, which is reversible. See here. See, and also MRI and other modalities cannot quantitate. We can quantitate the amount of myocardium, because more than 18 to 20% above, the patient will come back to normal. Left ventricular function will become normal, and the patient will get advantage. But in case of more than that, the less than that or more than that, it will be difficult. So we can quantitate the amount of myocardium here. So this is the reversibility pattern. So now many patients have got single vessel, double vessel functional significance of a borderline lesion. Suppose cardiologist does 50%, 60% lesion, 70% lesion, 40%. Whether these patients have got significantly perfusion defect or not. See, you can do a CT FFR or a catheter FFR. But that requires skill, that increases cost, and the person should be doing the papers with know the stuff we are going to do and everything. So, but here, to do is make the matter of scan. And so, and this particular patient, we have particular patient here you can see 50%, for that. Let's see how they can bring the this scan. So it's normal. So the patient is not dynamic, significant on the mic. So what is it? I like what is medical treatment. So the value of my already in the patient having significant coronary. They say what is significant? See, 100% lesion here. RC, this is 95%, 70%. Here the lesion, multiple lesion. So either you can do a viability studies asking for resting perfusion scan and LBG viability, or you can do it our MPI also. So here you can see here. See, now what you are getting it? Normal myocardial perfusion scan. Tell me, students, I'm asking question. How it is possible? How is it possible? Multiple lesions in the coronary arteries and the perfusion scan is normal. Stress perfusion scan. Stress was normal. Why? Because within over a period, the collaterals which has been developed, that is supplying to the stenosis area, the muscles supplied by is showing a normal myocardial perfusion. Then, what should be the treatment planning? Whether the cardiologist should go and do the angioplasty or this thing. If it is a left main, cardiologist must do it. But if suppose there is normal perfusion and patient does not have any symptoms, I have got 30 patients like that in Mumbai, and I have presented in CSI conference many times, and the patients are doing till today very well with the everything, and they don't have any problem. So this is called the interpretation of significant lesion in coronary artery. Now, 100% lesion in any coronary artery is reported by cardiologists. Do not attempt to do a intervention without doing the viability studies. I have seen doctors, Dr. Matthew, he has done that and without doing a perfusion scan, and after a few months, patient has come back to the physician, and physician referred to me, there is a breathlessness, and so when I did it, the already angioplasty, everything has been done and showing a fixed perfusion defect. That means the scar has been done. So if you open up an artery on a scar, so what will happen? The patient is symptomatic. So what is the treatment plan? Lifelong medical treatment. What will do? Okay. So, okay, these are restratification, infarct size and other things. This I do not want to go detail. High risk patients, these are the new areas. And yes, if the LV dysfunction is much more, then you can find the long uptake. This is called we give in our report a long myocardial uptake, 0.4 or 5 is normal, 0.79. So this is a follow-up of CABG patient after bypass graft. Bypass graft has been done, or angioplasty has been done. Patient comes with symptoms, whether the stent or the graft, LAD, Lima, Rima, whatever, or a superior venous graft working or not. So please do a stress myocardial perfusion scan. I'll show you a typical pattern of myocardial perfusion scan. Which one is ideal? Myocardial perfusion scan ideal. See here, this here, typical Lima graft blockage, LAD, a perfusion defect with a reversible scan. This is a typical pattern we get with the blockage of the graft or the angioplasty. So you can see here. Okay. So now calls the gated spec perfusion technique, last technique. So can you just what we do here in exercise in our department anywhere. This is a picture from Mumbai, Lilavati Hospital, where we are doing the exercise, and then we do the treadmill Bruce protocol. Then we find age predictor heart rate maximum, 85% either the heart rate should increase or systolic blood pressure and heart rate more than 25,000. So now the imaging is going on. Okay. So the image quality is extremely good with technetium level agent, and there is a state-of-the-art technique. The detection of stress into ischemia and quantitation already I have told you. Now you can see here. See the wall motion of a normal gated SPECT myocardial perfusion scan. Here you can see here, very good movement of the anteroseptal wall, inferior, lateral, anterior wall, and these are 3D image with a stress and rest. Please keep this in mind. I'll show an abnormal one immediately after this. Okay. So this is a normal perfusion scan which I showed you. Ejection fraction increased from 72 to 79, and there is no perfusion defect. Some stress score, rest score, and here normal. It's a normal perfusion scan. Just go to a abnormal scan. See here. So here what we are seeing it. Seeing a hypokinesia is there in the anteroseptal area, and in this thing it is bulged out the anteroseptal area in the 3D. Let's see how it behaves in the perfusion images. So here you can see it. There is a big perfusion defect on the anteroseptal wall, and also in rest, it is not reversible. It is not reversible. See here, some stress score 20 per, rest score will be 22. So hardly there is any difference score. So this is called a scar myocardium, where you cannot do angioplasty or bypass, either medical treatment or cardiac transplant. So persons who cannot do exercise, yes, we have got alternatives also. Then we can do the adenosine. Dipeptide, we don't do adenosine, dobutamine. We can do dobutamine is a positive inotropic and chronotropic. Adenosine works on the alpha-2 receptor blocker. Then here, indications, you know very well, unstable angina, amputated leg, osteoarthritis, knee joint, fatty patients unable to do adequate exercise. They are all indications. So prognostic value of MPI, large defect size more than 20%, multiple defects, defects with reversibility, large number of non-reversible defects, then TID ratio, they are all indications for high risk myocardial perfusion scan. Now comes the PET, positron emission tomography. As you know, PET is the gold standard for the assessment of myocardial viability. Gold standard. So they are the PET scanner where the patient is positioned. So metabolic PET tracers, we do F18 FDG. We do F18 FDG. Then F18 fluoropyridase is coming on all the way. The third phase the third phase was completed in University of California. It is coming very soon. So we can do the stress PET myocardial perfusion imaging. We are unable to do stress PET myocardial. We do stress PET myocardial perfusion scan. Once this cold kit will be available with us, that is F18 fluoropyridase, then we will be able to do the stress and rest PET perfusion. This is not very long way. It will be coming all the way, maybe by end of this year. And they are the PET viability protocol. We do. I follow European protocol, overnight fasting. But people, they give the IV, oral glucose, and then they inject. So I don't do that. But whatever protocol is not very important. So why assessment of myocardial viability is required? To evaluate the injured myocardium following ischemia or infarction, viable myocardium is most likely to benefit from revascularization, whereas scar tissue is unlikely to show functional recovery. So viable myocardium is two types: ischemic or geoparalyzed myocardium, stunned or hibernating myocardium. They are all ischemic myocardium, stunned or hibernating myocardium. Non-viable myocardium is the scar myocardium. Stunned myocardium is after an ischemic insult, then it opens up, then that amount of blocked time that produces dysfunction, but they are ischemic myocardium. Similarly, hibernating due to chronic myocardial ischemia. This is called hibernating myocardium. Then the isotopes we use, we started with thallium and PET, but they are all, you can see the mismatch pattern that here there is no perfusion in thallium. Here there is viability at the metabolism in the anterior wall. You can see that. So we started with this. Then this apical area also you can see here. Apical defect reversibility there. But then we started with the PET with resting scan. So you can see over here there is a perfusion defect here resting, and the PET showing viability. And now you can see a This I'll show you one beautiful case. Yeah. This is also same resting perfusion scan and the viability scan. And this particular patient is around 20-25% ejection fraction with a failure. You can see the failure signs and all. So here you can see the effusion. Then the patients were subjected for a resting perfusion scan and the viability scan. So here you can see the ejection fraction is only 21%. 21%. Let's see how is the viable microbiome. See, beautiful description of the anteroseptal perfusion defect with a viability in the septal wall and the anterior wall, and the patient was subjected by CABG surgeon, did it, and patient is doing very well with the ejection fraction improved from 21 to now it is 38 to 40%, and patient is doing well. Even failure patient also we can take. This is a patient where you can see fixed defect, anterior and apical, and resting. So this is a resting perfusion scan, and PET there is no viability. So this is a scar myocardium. So this is the red diagram, sensitivity and specificity. I just would like to have a comparison. You can see the PET scores over 90% sensitivity, but specificity MRI is little better than PET. But sensitivity, the PET is scores over every modality.
Sir,
Take home message
sir,
is
exiting the
time. Take home message is the best treatment strategy for patient with prior history of MI or ischemic cardiomyopathy, the viability and subsequent hibernation. FDG PET is not the emerging giant, but an established giant in determining the amount of extent of viability before any such coronary intervention required. So inflammation and infection, non-coronary disease can detect infection and inflammation. Since the time is not there, I'll have to go quick. Large vessel arteritis also FDG PET can diagnose. FDG PET vasculitis, and also you get Takayasu arthritis after steroids. Arthritis is gone. These are the atherosclerosis. They are the pre-therapy, post-therapy inflammations. So this is a case history of a infection on the cardiac device, that is the pacemaker. So patient was having fever, we detected that lesion, and sarcoidosis also, we can detect that. And the other all, then amyloidosis also, we do a FDG, you do a pyrophosphate scan, bone scan, you can see the agents, you can see the grade 1, grade 2, grade 3, and various types of cardiac PET CT procedures, stress PET, the images are there. Then non-invasive conclusion. So concluding, radionuclide imaging of myocardial perfusion, function, and viability has always been a centerpiece of clinical practice in nuclear cardiology and serves as a reliable tool for therapeutic guidance in ischemic heart disease. Today, molecular imaging of the heart is increasingly requested by cardiologists for infection, inflammation, and infiltration in amyloidosis and sarcoidosis, infant disease. Nuclear cardiology procedures are no doubt the state-of-the-art procedures in the present day clinical practice in diagnosis, prognosis, and guidance of therapy in CAD and non-CAD. Do you know why? Nuclear cardiology has a huge database, much before MRI came, much before. We have completed about 4 decades in nuclear cardiology when I was in MGH Boston in US. So this specialty has grown tremendously for the last 4 decades with the introduction of new imaging agents, modification, and other things also. So procedures are cost-effective, well-promising, having an increased sensitivity. So detailed overview of the okay. So this book we have taken out in our World Congress in Cardiac Imaging and Clinical Cardiology in 2019. And thank you for your attention. I would invite all of you to the 3rd World Congress on Cardiac Imaging and Clinical Cardiology from 6th to 8th October, Hotel Grand Hyatt, Santa Cruz East, Mumbai. Block your date. For students, postgraduate students, we are doing a certification course program. We'll take care of your stay for 3 days, and that will be a certification course program which includes echo, MRI, CT, and nuclear PET, and some clinical cardiology topics. And it is also approved by the MMC, Maharashtra Medical Council. You get the points, and then you'll get a certificate on the day of the test. Thank you all. Thank you. And I would invite any questions. I'm ready to answer that.
आप सबको बता दूं, सबसे पहले 1980 में सर ने मेरा परफ्यूजन टेस्ट किया हिंदुजा में. आपको याद नहीं होगा.
Acha, acha. I didn't know that. Yeah. Okay. Thank you, sir. Thank you. Any questions? Students, please come forward. Ask me. Any doubts?
Sir,
Or DM or
Sir.
MCA students who are there, they can ask.
sir, is there any importance? Sir, here.
Sure.
Sir, is there any importance of slices? Means higher slices से अपना PET scan की ये जो accuracy है.
Slices.
हाँ. 80 slice PET scan.
Oh, yeah, correct. I got a question. For the first time in India, we are, our honorable chairman has given us the 180 slices, which is coming all the way. What we are planning to do, what Manish has asked me, we can fuse the coronaries as well as the myocardial perfusion scan or PET, Dr. Jha, in one image. So you will get anatomy and physiology both. So more the slice, we are getting a beautiful slide. Nobody has got in whole Western India. 180 slices, we can fuse that we are with a third-party software, and you can give the anatomical and physiological. Again, about the coronary calcium score. So we can do each and every patient coronary calcium score and perfusion scan. We can combine also. Both the reports we can give it. With a beautiful machine from United System, which Dr. Bhandari has been giving us, and it will be coming very soon, within few days only. So in India, we are going the first person in India, not that in this department in SEMS, is going to give reports of anatomy and physiology in one report. Nobody gives. So we are going to have that.
Sir, good afternoon, sir. I'm Dr.
Yes.
Mahesh Kumar Jain.
Please.
Sir, recently we are receiving information that multiple young are having myocardial infarction and sudden death.
Hmm.
And as this is a non-invasive, so can we recommend this for the young
Okay.
less than 40 years of age as a screening
Yes.
for the early detection of myocardial
Okay.
infarction?
Okay. So yes, now the trend of as Madam also has spoken today, that Stanford is come out with the app. I have gone to the app. See, what you have been asking is a very good question. In India, I have done that project in Mumbai. Many young patients, 25, 30, 31, 35, they are having sudden cardiac death and other things, and they are having significant lesions. I have worked on that. And what you are suggesting is, that's a very good thing, a non-invasive, non-painful, no contraindication, no radiation. We can do a screening test as the SPECT myocardial perfusion scan, stress and rest study. I mean, this can be done, no problem about that, as a screening test.
Thank you, sir. So what will be the cost?
Yeah, I think the cost is, if you compare with the angiography and other invasive tests, the cost will be around, say, 10,000 rupees only. That's all. And when you are going to give the coronary calcium score with this, so little bit of more hoega, but it will be very competitive. Angiography cost, I don't know about same in Bombay, 25 to 30,000 angiography cost. And if you include FFR, then the price goes more. Catheter FFR. So it's about 9,000-10,000. It's not a very big, we can do that.
Thank you, sir.
We have to start the screening programs at the age of 30. We have losing people between 25 to 35. All practicing cardiologists are seeing that we are losing so many young lives. The answer lies that we have to popularize the concept of knowing your numbers. That means you have to screen your population. Every person in your community or society, wherever you are practicing, should know the BMI, waist circumference, blood sugar, blood pressure, cholesterol, and on top of that, the family history, because it's a mixed interaction between genetics and environment. So that's the key. You have to screen and popularize the concept of know your numbers wherever you practice. That's the number one. On the basis of this information, you have to calculate the risk. If your patient is at low risk, just ask for lifestyle intervention. If your patient is at intermediate risk, you can utilize as suggested by Dr. Mahapatra. But at the moment, as the cost of CT angio is coming down, more and more societies and people are accepting CT angio as a screening tool along with the coronary calcium in intermediate risk category. In high risk category, of course, they have to go for all invasive investigations which are required.
I just to add to Dr. Gupta's what he is saying about coronary calcium score and studies. What we have seen, I have done that paper and presented in Cedars-Sinai Medical Center. If the coronary 0 to 10, 10 to 100, 100 to 200, 200 to thyroid. So Dr. Gupta, more than what I have seen, I have done it. More than 200 or 300, I was quick. I want to show the slides. More than 200 to 300 coronary calcium score, you need a SPECT stress myocardial perfusion scan to rule out exercise-induced ischemia. But not 0 to 10, 10 to 100. No, not at all. Number two, what he is told, that I have seen many young patients having a strong family history of sudden death, cardiac disease. So I have come across such type of patients. Such type of young patient collapse. But if you take the history, yes, unke father ka heart attack aise hua tha, suddenly collapsed. So strong family history, and as he has correctly pointed out, the hyperlipidemia, dyslipidemia, these are the risk factors. You can do a screening test. And regarding the coronary angiography, one point only I want to tell you. Yes, you can do coronary angiography, but only problem is that if you do a coronary angiography, you will find a borderline lesion. 50%, 60%, Dr. Jha, 70%. Then the cardiologist will not do it. Cardiologist will say, okay, you do a stress myocardial perfusion scan, whether 50%, 60% is producing what I showed in my slides, hemodynamically significant perfusion defect. Then only do it. Then number three, Dr. Gupta, I want to ask you, Dr. Gupta, if suppose there is a borderline lesion or a sigma lesion, again, cardiologist, I'm asking you the question.
Yeah.
Cardiologist will not do without doing an angiography. So why that should be a duplication? Why you do coronary CT angiography and coronary angiography? No cardiologist do angioplasty or anything without doing a coronary angiography. So why not a physiology study SPECT myocardial perfusion scan? If SPECT myocardial perfusion scan done properly by an experienced person or by a fairly experienced person, if it doesn't show any significant myocardial defect, then do no risk. Risk is less than 1%. Less than 1%. So why not to do that? If it is producing perfusion defect, so I would not agree with Dr. Gupta. Go for angiography and angioplasty. So why you want to put CT angiography here?
Sir, we are getting late. Just one point that one should remember, that the lesions of 30 to 50%, they are responsible on majority of MIs, not those who are 85 and 90s. By CTA, you can detect those lesions. By intensive medical therapy, you can stabilize those lesions and you can postpone and prevent the future cardiac events. Next session.
That is called atheromatous plaque. What are you talking about?
We can debate it later.
Thank you. Thank you for giving me an opportunity to speak to you.
Thank you, sir. Thank you for your detailed and excellent talk. Now, I would like to call Dr. Suesh and Dr. Nishant for their presentation. Please come on the stage, please.
A very good afternoon to all my seniors and colleagues. I know we are running short of time, so I would like to sum up everything in minimum time. Firstly, before discussing the interesting case, I have been given an opportunity to discuss about the working of the Department of Cardiology in the past few years and our future projects. So starting with this, Department of Cardiology is one of the departments, many departments that we hold at SIMS, and it is having a continuous interaction with all the other departments, whether it's cardiac fitness, whether it's 2D echo or cardiac opinion. Every patient goes through this Department of Cardiology. So coming to that, the cardiology department is having a conventional cath lab at present at the second floor in Mohawk High Tech Center. There we used to do lot many procedures that we will be discussing on. This is our cath lab at present. And these are the list of procedures that we have been doing since last 5 to 6 years, including the angiographies, angioplasties, balloon mitral valvulotomies, device closures, pacemakers, peripheral angiographies, renal angioplasties, peripheral plasties, carotid plasties, even the high-end procedures like TEVAR and EVAR, and the regular procedures of pericardiocentesis as well as temporary pacemakers. So
I welcome Dr. Rakesh Jain sir, Dr. V. Siva Subramanian sir, Dr. Gaurav Singh sir, Dr. Manoj Kela sir, Dr. Sanjukta Bhargav ma'am, Dr. Advait Prakash sir to come on the dais.
So I think we have paused on the correct slide. So that you can see so many procedures have been done in the last 1 year, and these procedures have been going on increasing as the incidence of cardiac diseases and its early diagnosis are being going on increasing. So the demand of the era is a high-end center, that is the Heart Command Center, with the elite vision of our founder chairman, Dr. Vinod Bhandari sir. We are heading towards a state-of-art cardiac facility where we will be having all the different cardiac modalities under one roof, which will include the 2 new state-of-art cath labs, the advanced biplane cath lab modality with integrated cardiac imaging facilities that we have all coming to the knowledge in the nearby time, that the IVAS facilities, then the EP system. Many a times our residents have been struggling for the EP study and radio frequency ablation procedures. So from the coming years, we will be having these procedures at our center also. Cardiac 3D mapping and ablations for AF and VT, along with the high-end devices like CRTD and the AICDs. These new cath lab will be compatible with softwares that will allow us to do the high-end complex procedures, the structural and valvular interventions, the TAVI procedures that has been a new boom in cardiology, along with the TEVAR and EVAR procedures. Also with high calcified lesions that we are discussing, we will be having a ROTA facility at our center that will be allowing us to break that calcium easily and deal with all those difficult complex procedures, also with the help of IVL, which is the latest technology. This is the model of our new cath lab. It is a high-end biplane cath lab. As you can see, there are 2 plane C-arms. This will be having us to do procedures at a very minimum radiation as well as a minimum dye exposure to the patient. These are the modalities of this new machine. It is having a high resolution dynamic coronary roadmap, a stand boost live facility, 3D rotational angiography method, live 3D roadmap, and expert CT modality. In this expert CT modality, we can get the soft tissue images that we get in the CT scan. So with that, we can plan the procedures and do it at the same time itself. This is the demonstration of the stand boost facility, which helps us to know about the stand sizing as well as its proper expansion. Now, this is the dynamic coronary roadmap method that we'll be having at our new center. This shows that without giving the dye, we can get a continuous roadmap of the coronaries that will be helpful for us for wiring as well as ballooning and stenting without using the repeated dye. So that will reduce the contrast medium, the radiation time, as well as the dose of radiation exposure to the patient as well as the operator. And now in the coming era, the demands are increasing. So only stenting is not enough. So that's why we need imaging. And in this imaging era, we are having a cath lab which is having an inbuilt IVUS system so that we don't need to call anyone from outside for this imaging process. And side by side, along with the stenting, we can have the IVUS and OCT imaging also. This imaging helps us to know about the stent, the vessel size, and the stent proper expansion. So this will reduce the chances of acute stent closure, as well as that will reduce the chances of stent failure. These are the descriptions where IVUS is the ultrasound based technology, infrared based technology is OCT. Both are having its own merits and demerits. So both are useful at different point of time. This heart command center is not only having the new facilities, but it is also having 4 DM cardiology residents also, which will be in-house. And this is something which only our center will be having. Also, there are many non-invasive cardiac imaging modalities that we have already discussed. So I will include the 3 Tesla MRI. So now we will be having a cardiac MRI also at our center, along with cardiac CT and PET and SPECT gamma camera. Also, there will be a 25-bedded dedicated cardiac ICU, and there will be a separate cardiac rehabilitation program. So only stenting or revascularization is not over. The story for rehabilitation starts after that. This is the current picture where the model has been designed for the heart command center. This will be covered up in another 2 to 3 months, and we will be having it functional by 6 months period. Now coming to our case, this is a very rare case, and the purpose of keeping this case here is to not only show the difficult complex cases that we are doing, but also to emphasize on the teamwork that we are doing, and also the patient and doctor interaction and taking the decision after that whether which intervention they want to go for. So this is a rare case of rheumatic valvular stenosis with large pulmonary AV malformation. As we can see, she was a 50-year-old female and was having NYHA class 4 dyspnea, was diagnosed outside and was advised for open heart surgery at various centers. But the issue was the patient and her spouse was not willing for any open heart surgery. So when the patient came to us, she was in class 4 dyspnea. The first thing was to stabilize the patient. So we admitted the patient and stabilized it. These were the routine investigations which pointed out towards the severe mitral stenosis. That was the most prominent thing that was leading her to class 4 dyspnea. Along with that, there was a saturation of 69 on room air, which was due to the 3 large pulmonary AV fistulas in the left lung. So all the other blood investigations were normal except HbAg, which was found to be positive. So now we have come to the final diagnosis, and now here comes the role of heart team approach. So at our center, we have a cardiothoracic surgeon full-time along with an interventional radiologist and an interventional cardiologist. So we all have sat together, and then what can be done for this patient, we have decided which thing will be beneficial. Along with our point of view, we have also taken care of the point of view of the patient. And as the patient was not willing for an open heart surgery, so we advise them 2 modalities of treatment. First is the percutaneous route treatment, which included in stage 1, we will first open the valve by a balloon mitral valvulotomy. And then in a stage procedure, after stabilizing the patient, we will go for the closure of the AV malformation, either with the device or with the coil, because the size of the AV malformation was quite big. And the other option was always there for mitral valve repair or replacement and closure or ligation. And also in case we fail for any of the percutaneous procedure, we were having the surgeon on our side who can take the patient for OT at any time. So with the common consensus, we move toward the percutaneous closure. And first the stage balloon mitral valvulotomy procedure was planned. So as we can see, these are the few steps. I will go very quickly. First, we are doing in case of balloon metal valvulotomy, we are going from the IVC to the right atrium to the left atrium. So for that, we need to puncture the septum. The atrial septum has been punctured in the step 1. Now in step 2, there is a coil wire that we are placing in LA. And then in step 3, we are introducing the balloon. As you can see in step 4, the balloon is being inflated and then it is pulled back towards the mitral annulus. And in stage 5, there is full balloon inflation according to the size and height of the patient. This balloon has been planned and then we inflate the balloon for a few seconds and then deflate it. The purpose of inflating this balloon is to break the commissures and relieve the patient from mitral stenosis. These are the cath images of the procedure. In step 1, we are doing the transseptal puncture. As you can see, the dye is filling the left atrium. In the second, this is the left atrial chute, and then we have introduced the coil wire. This is the septal dilator, which has been used before introducing the balloon through the septum. And in the final stage, we have introduced the balloon, inflated it, and then pulled it back to the mitral annulus, and then inflated it to the full size. And this led to the breakage of the commissures and relief of the patient from the mitral stenosis. There were the cath data with the gradient was significantly reduced from 25 mmHg to 4 mmHg. And along with that, the echo findings showed that the mitral wall area was successful BMV requires doubling of area. So we had an area of 1.76 with acceptable mild MR, and the PA pressures fallen down significantly along with the split of the anterolateral commissure. So the first step of the procedure was been done successfully. Then we took out the patient and we stabilized the patient for 3 to 4 days. Then after that, the teamwork comes again. We involved our interventional radiology team and the structural team. And then we planned for another procedure, which was the closure of the AV malformation by the device and coil. To go into further detail of this procedure, I would like to call my colleague, Dr. Nishan Bhargav from Interventional Radiology, to explain the difficulties and how we dealt with that in the procedures that we have done in the stage 2. Thank you very much for the patient listening.
Good afternoon, everyone. I'm Dr. Nishan Bhargav. I'm working here at SAMES in the capacity of an intervention radiologist as assistant professor in Department of Radiodiagnosis. I'll be discussing the case of pulmonary AVM. So the Department of Cardiology and Intervention Radiology, they generally go hand in hand, and it's a team approach, as has been discussed by Dr. Suyash. First, for this patient, the BMB was planned. The BMB went on successfully, and the next stage was to deal with a large pulmonary vascular malformation. These are the number of cases which we have done in past 1.5 years. So I'm proud to tell that in past 1.5 years, the total number of vascular cases we have done is around 400. And the complex procedures, including the aneurysm coilings and AVM embolizations, we have done approximately 100 cases at our institute, which is a big number. Coming to the case, the clinical details have already been discussed. Patient presented to us with cyanosis and exertional dyspnea. She had rheumatic heart disease. And this was the CT angio where we discovered a large, ugly looking pulmonary AV malformation. So this was a large malformation in the left lower lung, which was being fed by multiple segmental branches. Also, she had 2 small vascular malformations. This was a case basically of hereditary hemorrhagic telangiectasia, HHT. So what is a pulmonary malformation or a pulmonary AV fistula? When there is a direct communication of the artery and the vein with fusiform aneurysmal dilatation or a nidus of vessels present in the intervening network. The capillary network is absent in such cases. So what happens is there is direct shunting of the blood. Now this direct shunting in the lungs, what it leads to is non-filtration of the blood, which can lead to brain abscess, which can lead to strokes. Other thing is that this aneurysmal dilatation may rupture because of the high pressure, leading to life-threatening hemoptysis or hemothorax. Basically, pulmonary AVMs are generally seen in have a female predilection and more common in middle-aged females, and 70% of the cases are associated with HHT. Natural history, as I've already discussed, being most of the patients present with stroke or brain abscess. They may have respiratory failure because of hypoxemia or life-threatening hemoptysis or hemothorax. Now, these are classified as simple type where we have just a single feeder, and a complex type where we have multiple segmental arterial feeders, our case being the complex one. Compared to most of the AVM in the body, the pulmonary AVMs do not affect the cardiac hemodynamics. Most of the cardiac parameters are usually normal, and the degree of clinical effects depends upon the amount of shunting which is present. Okay, so how do we diagnose a HHT? When there are multiple mucocutaneous malformations or GI malformations, along with other body malformations, as well as history of spontaneous or recurrent epistaxis, and or if there is a first degree relative with HHT, then if the three criteria are fulfilled, it's a definite HHT. In this particular case, patient had multiple pulmonary AVMs. However, there were no oral or mucosal AVMs. We do not know about the GI perspective yet. She presented with cyanosis, had clubbing, and on auscultation had pulmonary bruit. On ABG, PO2 was around 47 mmHg. Now, the mainstay of the treatment earlier used to be surgery. Now, the mainstay has become embolization, wherein the AVMs which we treat are those having feeding arterial diameter of more than 3 mm. If the diameter is less than 3 mm, it can be left, but if it is symptomatic, it has to be dealt. The change from surgery to embolotherapy has come along with the advent of Implantar vascular plugs. Now, what are these plugs? These are nitinol mesh-based device which expand within the artery and gradually block the artery. So what we do is we deploy them in the feeding vessels, and gradually the feeding vessel gets thrombosed and the AVM gradually gets thrombosed. So these are the angiographic images. You see here, there is a large shunt with multiple segmental feeding vessels. Just a second. Okay, so here's a large shunt. You see direct feeding of the artery and going into the large pulmonary vein. What we do is directly enter into these shunts. We go distally. First, our plan was to deploy plugs. We were having some difficulty to drag our sheath downwards. So we started with the small feeders. We started coiling the AVM. But what we saw was that coils were not enough thrombogenicity. There was not enough thrombogenicity in the coils, and the flow was still seen beyond the AVM. So but after multiple attempts, we were able to drag our sheath downwards into the main feeders, and then we started deploying our vascular plugs. Now you see in the restrained form, the plug looks like this, and as it gets opened up, it's a dumbbell-shaped Implantar vascular plug. There was another large feeder, which again we performed Implantar vascular plug. So we deployed 2 plugs and around 2 coils, and this was the final result where we see significant slowing within the AVM, and over a half an hour or an hour period, it will get completely thrombosed. So the discussion being the current guidelines, where I have already discussed, pulmonary AVMs with feeding artery more than 3 mm have to be dealt. However, in the symptomatic individual, size doesn't matter and you have to treat it. For all the patients with pulmonary AVMs, if you are treating them or not treating them, the guideline recommends frequent follow-ups and antibiotic prophylaxis to prevent the risk of sepsis. Thank you.
Thank you, Nishan. With due respect of Chairman Sir, VC Ma'am and Gupta Sir, I like to invite the one cardiac team is here. Remaining persons are below the dais. So I invite Dr. Ram Shukla Sir to have some. Nishan, you stay here. Ram Shukla Sir, Dr. Nishit Bhargav, Dr. Prashant Agrawal, Dr. Suyash Satet. So please come on the stage So we can have group photograph or as per. Yes, yes. So already we are knowing Dr. Nishan Bhargav is interventional radiologist, and he has done a lot of cases. Dr. Ram Shukla sir, he is a adult cardiac surgeon in our institute since last 3 years. He has done many cases. Dr. Prashant Agarwal is a pediatric cardiologist. Dr. Nishit Bhargav is a pediatric CTVS surgeon, and he has already doing a lot of cases and difficult cases. I think in Indore, there are very few pediatric CTVS surgeons. Dr. Sanjukta is with us, please. Yeah. So she's a pediatric cardiologist. The adult cardiologist team already, sir, introduced Dr. Gupta, sir. You want to?
We have got the young dynamic interventional cardiologist, Dr. Suesh, Dr. Gaurav Singh, and Dr. Rakesh, and I'm heading the department. Thank you.
So shall we proceed or we can have a small break? Thank you, all of you. Now we will move ahead. I invite Dr. Ram Shukla, sir, for some interesting case from CTVS department. Sir, before you start your lecture, can I say something? So recently we have a very difficult case. We did a laparotomy. Second day I took round in ICU. Patient was ambulated as per the protocol. And suddenly at 2:30, Dr. Abbas call was done in view of some tachypnea. We were suspecting pulmonary embolism. That was defined. And 3:30, Dr. Ram Shukla sir has given order to ship patient in the OT. 4 o'clock, he opened the thorax. He did pulmonary embolectomy. And that was a very difficult case. Till now, I have not seen such type of case. And that patient was discharged after 10 to 15 days with a massive pulmonary embolism. So I think that is a very creditable for us.
As there is shortage of time, good afternoon, everybody. First of all, good afternoon, Badai sir, Manoj Kela sir. And as Dr. Manoj Kela sir has already given a short review of this rare case presentation, this was a case of acute pulmonary embolism, and emergency pulmonary embolectomy was done in this case. And the case was post-op case of ileal stricture repair and portal mesenteric vein thrombosis. The patient presented with pain in abdomen since 15 days and had intermittent obstruction on and off on giving feeds, and on making the patient nil orally, the patient again became normal. But the patient's symptoms kept on persisting for 5 to 7 days on his admission date 15/11/22. The patient had recurrent vomiting, abdominal distension, and decreased appetite and constipation on giving feeds, which subsided on making the patient nil orally. There was no significant past history, and during this course, Dr. Manoj Kela sir had decided that we'll go for CT and CT abdomen, which showed small bowel obstruction with pulmonary vein thrombosis and mesenteric vein thrombosis. This was the X-ray done pre-operatively, and this is the CT film which showed portal vein thrombosis along with mesenteric vein thrombosis. On the day of surgery, on opening the abdomen, the patient had ileal stricture, and along with it, there was a band which was compressing the ileum part. It was around 340 centimeters away from the DJ junction. A resection anastomosis of 7 centimeter bowel loop was done, and end-to-end anastomosis was done. Next day, as Dr. Manoj Kela sir said that the patient was okay at his rounds, but during afternoon again he started desaturating, having a lot of tachycardia, tachypnea, and despite giving medications, the heart rate remained around 160. Immediately, a CT-based opinion was taken, and we had planned for a urgent pulmonary embolectomy, as Dr. Swish on his echo had showed that there was a thrombus inside RA, and MPA, LPA, and RPA all were dilated with very high PA pressures, and RA and RV also showing distension. So this is the photograph taken during OT. The patient was taken on cardiopulmonary bypass, and we had decided that initially that we'll have to give a total circulatory arrest and then take out the clots, because it appeared to be a very difficult case. The heart was very much dilated. When we had put the patient on bypass, beating heart, we took out the clots from right atrium, IVC, SVC, and then we thought that let's go beating heart, and if the patient tolerates. And so we were lucky that we were able to take out these clots, beating heart. As you can see that the heart is still beating, and we were taking out clots from the pulmonary arteries. This is the clot coming out from LPA, RPA, and we had to go to all the lower branches of pulmonary artery, bronchopulmonary segments, and subsegmentally we were able to suck out the clots. So you can easily see how long the clot was there, which was having one end in SLC, the other end in the IVC, and the clot had a knot inside the right atrium. And on the right and left pulmonary arteries, we had lower segmental and subsegmental clots, which are clearly seen in this diagram. So this is operative operatively. So lessons learned from this the patient has been get to the end of section and CTS abdominal will show the total vein thrombosis. So patients are prone for developing deep vein thrombosis, and the DVT prophylaxis lags a little bit, then these patients post-corona may develop hypercoagulable state, and these portal vein thrombosis patient along with mesenteric vein thrombosis may develop DVT and acute pulmonary embolism, because these patients are usually dehydrated preoperatively, and this can lead to a catastrophic event. We were lucky that the patient's bloods were arranged post-operatively, because a day before resection and osmosis were done, and immediately we were just about to move out of our OT, and by that time the call came, and so we were able to plan this urgent surgery quite well, and the patient's life was saved. So post-operatively, we can have early mobilization of these patients, but if at times they are not able to mobilize, we can go for compression stockings and anticoagulation prophylaxis should be adherent to in such cases of hypercoagulable state who already have portal vein thrombosis and mesenteric vein thrombosis. So these are two scores which are available with us. This is a 2019 article with a Caprini score and a Rogers score. These scores are for colorectal surgeries basically, but we can take some points from these scores and apply these scores for managing such high risk patients who are prone for hypercoagulable states, and such catastrophic events can be avoided. So this is one case which my younger brother Ramon Shukla had presented when he was in RD-Gardi, and this is also isolated case of tubercular jejunal stricture with associated portal and superior mesenteric vein thrombosis. A very similar case, but it didn't presented with DVT and pulmonary embolism. So in this case, I would like to request Dr. Manoj Kela sir what could be the cause of stricture? It was the band, or it was because of the portal vein thrombosis or mesenteric vein thrombosis?
Sir, I think there can be both etiology. A band was already there, so it was causing some serosal impact, or it was not, means food material is not progressing. Means the patient was not in a 50% condition whether to operate or not. That's why we waited very long, and this patient was referred to us by gastro team. Dr. Arun has said, even after diagnosing, means he came for portal vein thrombosis, but incidentally on CT scan, he diagnosed patient was in obstruction. As soon as patient came in the surgery department, he was passing motion platters. So we decided to go for conservative treatment with anticoagulation treatment for portal vein thrombosis. But suddenly we found this patient needs some type of intervention. So we explore and we found a band there.
Okay. So histopathology report of this patient of 7 centimeter segment, which had 1.5 centimeter size structure, which showed mucosal ulcerations and mixed infiltrate, which was showing a kind of a chronic venous insufficiency in inflammation, could be because of the band, or could be because of the portal vein thrombosis or mesenteric vein thrombosis leading to venous congestion. Just like in DVT, we have chronic venous ulcers, they can be present inside the bowel also, and similarly, it was a unique case.
Yes, sir, definitely. And I think it is with this patient can be treated only in SAMES and with a very good team approach. Mainly PG has done very good efforts for these patients.
Thank you, everybody.
Thank you, sir. Now for next lecture, I invite Dr. Prashant Agrawal to speak on pediatric cardiology case.
Very good afternoon to all of you. Myself, Dr. Prashant Agrawal, consultant pediatric cardiologist in Mohawk and SAMES. Before I would be discussing the varied presentation of pulmonary AV malformation. So before discussing it, I'd like to tell something about my work in SAMES and Mohawk. In last 1.5 years, we did around 150 cardiac procedures in pediatric age group, with 55 procedures in structural heart disease in grown-up adults, including balloon mitral valvotomy and balloon pulmonary valvotomy in pregnant females. So we could continue the pregnancy till term. And in all these procedures, I had only one intra-procedural complication. So the rate is almost less than 1%, which is at par with the international standards. I'd like to tell the 90% of our kids, these all pics are of just a very next day of the procedure. And mostly kids were discharged on the very next day of the procedure in the walking state. And average stay of the kid which I operated were only 3 to 4 days in our SAMES or Mohawk. And all this number and all these cases are possible because of the liberal support of Chairman Sir, as well as my colleague, Dr. Sanjukta Bhargav, with the back support of our cardiac surgeon, cardiac anesthetist, and Department of Pediatrics. Actually, we are having a state-of-art pediatric department with all subspecialties for detailed evaluation as well as stabilization of the kids. So I'll come on my case of pulmonary AV malformation. We are having a 16-year-old male with the complaint of dyspnea, breathlessness, and easy fatigability. Cyanosis was mild, though saturation was 78%, because the child was severely anemic with the hemoglobin of 2.8. Our pediatric team evaluated, and when CTPA was done, and along with contrast echo, it was suggestive of pulmonary AV malformation, though it was a part of hereditary hemorrhagic telangiectasia, which has already been discussed by Dr. Nishant and Dr. Suyash. So I'll cut short that discussion part. But as this was the case, as discussed by Dr. Nishant, that we did pulmonary angiography, we found the pulmonary AV malformation, and we closed it with the devices and vascular plugs. So this is the one presentation. This is the kit. You can see clearly the saturation rise from 68% to 92%, as well as the smile of kid just 1 day before to 1 day after the procedure. This is the case, but I just used this case as a reference case where we found straightforward pulmonary AV malformation. Now I came to my second case, which is we went a step ahead. A 8-year-old male child present with same complaints, referred for evaluation, cyanosis and pan-digital clubbing was there. Echo was normal. But when we went for CT pulmonary angiography, it was also normal. We did contrast echo. Contrast echo was suggestive of pulmonary AVM. This is a routine contrast echo I am showing for the reference. The bubble contrast was given in the right side of the heart. Usually lung capillary acts as a good filter. So contrast is not coming on the left side of the heart. But in this second video, you will see when bubble contrast is being injected in the right side of the heart, it is being crossed through the lung and the left side of the heart is also filled with the contrast, which shows the pulmonary AV malformations are there, whether it has not been picked up by the CT scan. We went for further evaluation and we find the portovenous malformation in this kid. There was a connection between portal vein and IVC, and that is the known cause to cause diffuse micropulmonary AV malformation, which cannot be picked by CT scan or CT pulmonary angiography. With discussing the team, we went for the angiography of this lesion. We did close this lesion with the device, and after this procedure, we discharged the patient on third day, and after 1 month follow-up, the saturation was picked up to 92%, and our contrast echo was negative after 3 months. So basically, it is a part of hepatopulmonary syndrome, which can present as arterial desaturation, pulmonary hypertension, intrapulmonary vascular dilatation, and liver disease. And after the closure of this lesion, the diffuse micropulmonary AVMs are vanished itself, because liver just makes the factor which just vanish these pulmonary AVMs. Thank you.
Dr. Prashant, thank you for presenting this case very nicely. As a pediatric and neonatal surgeon, I can very well understand how difficult it is to perform interventions in such small children. You and your team with Dr. Sanyukta have been performing wonderfully. And today itself in the morning, I have operated one large omphalocele, which Dr. Sanyukta yesterday did neonatal echo, and we detected ASD with PFO, which we will be dealing later on. Thank you very much for your presentation.
Thank you.
It is a pleasure, my pleasure, to now invite a very young, enthusiastic, and dedicated pediatric cardiac surgeon, Dr. Nishit Bhargav. Those who are not acquainted with him, he is an alumnus of JNM Medical College, Raipur, did his master's from there, and post that he did his MCH from the prestigious GB Pant Medical College Hospital. He has been in the field of pediatric cardiac surgery for the last 8 years and have performed more than 2,500 surgeries on these small children. He has shifted to Indore in 2019 and since then has performed more than 800 surgeries. He has recently joined SAMES 1 year back, and he has been performing variety of cases, pediatric cardiac cases. You'd like to share your experience with us. Dr. Nishit Bhargav, over to you.
Thank you, sir. Thank you for such a nice introduction. Good afternoon, everyone. Good afternoon to all the seniors, my colleagues and juniors. Well, it's been 3 years since we have come back to Indore, and it took us time. It took us almost 6 months to develop a unit because pediatric cardiac surgery was not something which was done very often in Indore or for that matter in Madhya Pradesh. So it took 6 months to train people and to start a unit. But now we can proudly say that since last 3 years, we have done almost 700 plus cases in Indore, and the results are comparable to any other good unit in India. So now we are running it with success. It's been almost 14 months since I've joined SciEMS, and I'm very happy for that. We have done more than 240 cases in last 14 months. This included whole spectrum of the pediatric cardiac surgery, from simple ASDs, VSDs, which are basically called as holes in the heart, to the most complex ones like a TGA, transposition of great arteries, or for that matter, the TAPVC. The weight distribution, well, our youngest patient was a 1-day-old child, 2.5 kgs in weight, and this extends still the adult patients who are suffering from congenital heart diseases. The average weight being 5 to 10 kgs. The age distribution again varies from the neonates, infants, to adults with congenital heart diseases. Amongst these cases, I would like to discuss just 2 or 3. I'll just brief on those 3 cases. Case 1 was a 16-year-old female, Shalini. She's from Indore only. We had operated her on in January 2022. She presented to us with complaints of dyspnea on exertion and palpitation since almost 10 to 15 years. And she was following with a lot of other people and was on medical treatment for the same. We did a echo and we found out that she was suffering from Epstein's anomaly. Now, it's a very rare anomaly of heart wherein the tricuspid valve is involved. It is basically failure of delamination of the tricuspid valve. Tricuspid valve is the right-sided AV valve. So out of the 3 leaflets, 2 are stuck to the wall, to the right ventricular wall, whereas only 1 leaflet, which is the anterior leaflet, which compensates and becomes like a sail-like anterior leaflet. And there is apical displacement of the septal leaflet. This causes severe low pressure TR and dilatation of the right side of the heart and eventually failure of the right side of the heart. How do I play this? Just to play this. So this is a pre-op echo. I hope the video works. Yeah. So in this we can clearly see so that okay, so on the right side we can see the tricuspid valve. We can see the leaflet and that is totally displaced down. This is the septal and septal leaflet and the posterior leaflet. It should have been over here. So this is basically leading to severe tricuspid regurgitation. To treat it, obviously the treatment is surgical, and the easy way out is you can replace the valve because it was a 16-year-old girl. But then again, the ideal treatment would be a repair. And we did a Cone's repair for this child, and we were able to successfully do it. In this echo, there's the post-op echo. You can see that the leaflet has come up and there's hardly any TR anymore. We did a Cone's repair. This is basically mobilization of the valve to its normal position with vertical plication of the atrialized right ventricle, and obviously the closure of the ASD. This girl behaved very well. She had a post-operative course which was totally uneventful. She was extubated on day 1, was off inotropes on day 3, and was discharged from the hospital in normal sinus rhythm on day 5 of the surgery. Second case is basically a case where it's not a rare case, but it's not something which we read or see traditionally. So it was a female, 6-year-old female, again operated in January, presented to us with dyspnea, palpitation, recurrent infections. She had multiple echos done outside, which was suggestive of a mixed TA-PVC, the right-sided ones draining into the SVC and the left ones into the coronary sinus. But when we did the echo in our institute, we found out that it was a supracardiac TA-PVC, which is a normal TA-PVC. But what was specific in this case was that instead of a left vertical vein, there was a right vertical vein in this case. That changes our surgical decision completely. So we did a repair. We found out the same findings what we saw in the echo. We did a posterior approach and we ligated the right ventricle vertical vein. And this is the image showing normally, now this is the right side of the heart. And this is the right vertical vein, which is draining onto this is the superior vena cava. Normally the vertical vein would be somewhere over here, the left vertical vein. But this was the right vertical vein, and unless you know it preoperatively, it is impossible to find out these things when you have already opened the heart. So that shows us the importance of knowing everything before we go in for the surgery. Again, the post-operative course was uneventful, was extubated on the same day, was off inotropes in 2 days, and usually we discharge our patients on 4th to 5th day of surgery. So traditionally, we read the classification of TAPVC as supracardiac, cardiac, infracardiac, and mixed. The only reason why I discussed this case was because in our practice in last 5-7 years, we have seen a lot more variety of these, and that's why we usually divide all of them into A and B. A being the normal drainage and B aberrant drainage, like in this case. So traditionally, this would have been called as a supracardiac case, but we call it as a supracardiac 1B TAPVC. The third one is just for the mere size of the gland which we had removed. It was a 3-year-old child who came with dyspnea on exertion and some noisy breathing. She has had X-ray which showed a huge thymic shadow and was compressing on the right side of the lung as well. So this is what we found out. We had removed, it's almost a 15 centimeter into 9 centimeter mass, weighing almost a kg with the fluid. So the dry weight was around 600-700 grams. And this was causing the main symptom. Luckily, it did not cause any hypoplasia of the right lung. And post-surgery, obviously, the child was relieved by all the symptoms, and she had an uneventful course as well. Thank you. Thank you for your patience.
Hello. Hello. First, I want to congratulate you to you have achieved more than 200 cases. You have done 200 cases successfully, because majority of the cardiac surgeon at Indore, they are doing cardiac surgery in pediatric age group, particularly if the age is more than 10 years or body weight is more than 9 kg. But you are doing here at the age of at the body weight of 2.5 kg. Nicely, it is a beginning of new era at the Indore for the pediatric cardiac surgeries. Thanks.
Thank you, sir. Thank you, sir.
Should I say something? Yeah. Also, as Ram sir said in the end of the slide, if trust your instincts. If you see any kind of abnormality, don't give up. Please look for the cause. Almost 90% of pulmonary artery hypertension will probably have a cause, and like Abhinathi malformation, we can treat it and relieve the patient. We can't stop searching until we reach all dead ends. Thank you.
Gupta sir, shall we continue or we can have break? Okay. So,
I would like to invite Dr. Rajkumari Rawat ma'am, consultant radiologist, for the introduction to new radiological technologies and machines.
A very good afternoon, everyone. This is Dr. Rajkumari Rawat, and I'm extremely happy to introduce all of you to the new radiological technologies and machines that we are going to have soon in our institution on the behalf of entire of Sri Aurobindo University. Soon there will be a technology boom in SAMES Campus 2023 with high-end product launches. These will be 3T MRI from Vida X3 from Siemens, 160 slice fast PET scan system from United Medical Systems, 128 slice CT scan, incisive from Philips Medical System, biplane cath lab Azuron from Philips Medical System, monoplane cath lab Wipro GE Medical System. So this will be the first biplane cath lab of Central India with most advanced features, with world-class expertise in cardiac and neurovascular procedures. It will include coronary angiography, cardiac angioplasty, pediatric cardiac interventions, transcatheter aortic valve implantation, pacemaker, electrophysiology and ablation, neurovascular imaging, including cerebral angiography, aneurysm coiling, AVM embolization, cardiac angiography, angioplasty, stroke management, peripheral angiography, and interventions, including thoracic endovascular aortic repair. This advanced technology helps to optimize patient comfort and enables us to provide an advanced level of care for the patients. So this would be the first digital PET scan in entire of the central India. It is a complete digital PET with highest accuracy of detecting sub-centimeter lesions. It would be faster and it will complete the entire of the scan within 5 to 6 minutes. It will reduce the patient dose to radiations approximately 50%. It has high definition images for detailed information, and it would be one-stop cardiac imaging solution with 160 slice CT, cardiac CT. The next would be the 3T MRI system. It would also be the first of its kind in entire of the central India, delivering precision imaging and speed with Siemens Magnetum Vidas XT. Approximately 75% of the MRI examinations are planned automatically, driving workflow, speed, and consistency. This 3T system would be provided with a lot of technologies, including biometrics technology that is automatically adapting to patients' biovariability. They will be providing us with a quiet suite. That means that the basic problem with the MRI is the sound pressure to the patient that will create anxiety to the patient. Patient would be claustrophobic, and it is also a problem for the patient who are pediatric. And this 3T MRI system would provide us with the reduction of approximately 97% in the sound pressure with no compromise on image quality. They would be providing us with TIM 4G coil and RF technology, which eliminates patients' repositioning need and manual coil changes during the scan that enhances the image quality. There would be a wide bore of approximately 70 centimeters with flared opening suitable for claustrophobic patients with highest patient comfort. There would be a gradient technology for faster and high resolution imaging. There would be a turbo suite for 50% faster MRI scans compared to the conventional scans. There would be a lot of new technologies for many breathing-free examinations, improving the patient's care. And these advanced clinical applications will include high-resolution diffusion imaging, free breathing cardiac variability imaging, advanced metallic artifact reduction techniques, motion corrections, whole body imaging, non-contrast imaging, advanced neuro applications. So the next thing would be a CT that has just got smarter, that is incisive CT, the next generation CT scanner with 72 centimeter bore size. It will have a lot of nano panel detectors that will provide high dynamics range of imaging for the better visualization of low contrast objects close to the high contrast objects, and would be beneficial in low kV pediatric imaging that would be down to 70 kV. These nano panel detectors are different from the conventional detectors. In the conventional detectors, there would be a limited dynamic range as compared to the nano panel detectors, which will be providing us with full dynamic range and higher image details as compared to the potential detail loss. It would be providing us with beat-to-beat variable delay algorithm that would be helpful for variable heart rates and high heart rates up to 120 beats per minute. It would be having a max cycle, that is adaptive multi-cycle reconstruction, to achieve a temporal resolution down to 53 milliseconds. So this adaptive multi-cycle algorithm, we would be able to take the images in 4 cycles of the heart, and everyone needs to 180 degree to reconstruct an image with this. Any of the ectopic beat that has been different from the beat that we have set in the machine previously could be reconstructed, and there would be no loss of the image quality. They will be providing us with a 70 kV protocol. It is a low dose protocol which allows improved low dose contrast detectability with diagnostic confidence. It approximately reduces 20% lower dose for the patients. We have opted for iDose premium package along with metal artifact reduction for large orthopedic implants, that is OMAR. So what happens whenever we are performing any of the MRI with a metallic implant, there would be a lot of metallic streak artifacts, and different type of artifacts that would be seen. And in the vicinity of these artifacts, we would not be able to detect any of the lesion or the disease. They have provided us with a iDose premium package in which there would be a reduction in the image quality, and there would be reduced artifacts, so we would be able to detect the disease more precisely. The next different thing we would be having is 1000 by 24 to 1000 by 24 metrics. That is 4 times better than that what we are offering in the industry, that is 512 by 512. So what happens is, like, this is the pixel size, and in the conventional ones, the pixel size would be of 0.625 by 0.625, whereas the metric size in 1000 by 24 by 1000 by 24 that we are opting for, the size of 1 pixel would be 0.313 by 0.313. That will improve the detectability of small objects and reduce the need for additional scanning. The gantry ribbon lights would be there. The yellow when the X-ray is on, white during the patient registration, and green is to start the examination. There would be intelligence that adapts you to on-plan patient-side gantry controls that will help to minimize the time spent away from the patient. The technicians need not to move all the time from the patient to the console, and it would save the time. The improved workflow with gantry touch screens that would decrease the time by approximately 19%. And we are extremely excited to have these machines in our institution. This will help us to diagnose the disease better and will help you to treat the patient better. Thank you.
Thank you, Dr. Rajkumari. We all look forward to all these technological advancements in our institute that will help all the clinicians and to the society at large. I thank all the presenters of this session, namely Dr. Suyash, Dr. Nishant, Dr. R.K. Shukla, Dr. Prashant, Dr. Nishit, and Dr. Rajkumari for sharing their experience. And on behalf of my fellow chairpersons, I thank the Department of Cardiology also for arranging such a nice CME and making us part of this academic feast. Thank you. Over to the Master of Ceremony. Next session. We look forward for next session.
Now I would like to welcome respected Dr. R.K. Jha sir, Dr. Dolly Joseph ma'am, Dr. Shahid Ali Abbas sir on the dais. I request you to proceed with the program.
I request Dr. Rakesh Zaid for his lecture, and he will speak about the clinical evaluation management of pulmonary embolism. Over to Dr. Rakesh Zaid, because most of us is knowing Dr. Rakesh Zaid, and he is working with us before the inspection started, and he is now regular. He is working as associate professor.
Good afternoon to all. Respected Bhandari sir, Jyoti Bindal madam, my seniors and colleagues. Today we are going to discuss about the pulmonary embolism, clinical diagnosis and management. Pulmonary embolism is a condition where thrombus usually get formed in the proximal venous system of the lower limb and migrate through IVC into the pulmonary arteries. This is not an entity related to cardiology only. In fact, we are seeing these cases all in other departments. after surgeries and orthopedic surgeries, GI surgeries, prostate surgery, after bariatric surgery. All these are going to happen once in a while. So what are the most common risk factors? The patients who develop pulmonary embolism is a fracture of the lower limb, previous VT, spinal cord injuries, which requires long immobilization, hospitalization for the heart failure, hip or knee replacement, major trauma, and myocardial infarction within 3 months. So how to presume or how to predict the possibility of the pulmonary embolism? If any patients, usually day 3rd of the surgery, having acute onset of dyspnea, chest pain associated with or without syncope, presyncope, tachycardia, tachypnea, with or without hypotension. Our first diagnosis should be acute pulmonary embolism until proven otherwise. Another dyspnea may be central or may be severe if the embolism is in the main pulmonary artery or is MPA or RPA. It may be mild, if particularly pleuritic type of chest pain, if the embolization goes in the peripheral areas. So basically, these are the way how to first presume or first to diagnose pulmonary embolism. Once you suspect pulmonary embolism, this is the clinical criteria, the revised Geneva clinical prediction rule to assess the probability of the pulmonary embolism. So these are the different parameters. It is basically on the basis of these parameters, we divide either low risk, intermediate probability or high probability for the pulmonary embolism, depending upon the total score. Once we got that this patient is having possibility of the pulmonary embolism, go with this chart. This chart should be available in each and emergency department and post-operative care wards or ICU. If the patient who is suspected of pulmonary embolism and having hemodynamic instability, I will tell what is the meaning of hemodynamic instability in the next slides. So if that is there and you are suspecting pulmonary embolism, first test to be done is transthoracic echocardiography. If you are seeing RV dysfunction, if there is a sign of right ventricular dysfunction, if it is there, go for CT pulmonary angiography immediately. If it is not available, then treatment of the high-risk pulmonary embolism should be started. But if CT angiography is negative, search for the other cause of the hypotension or instability. It is not a pulmonary embolism. But if on the first test, that is the echocardiography, if RV is normal, it is not a pulmonary embolism. This is for the patients who having suspected pulmonary embolism with hemodynamic instability. There is no role of D-dimer in such cases. So don't send D-dimer, go for the echo test, followed by CT pulmonary angiography. So what is the meaning of hemodynamic instability? It means patient develop cardiac arrest who requires CPR, or if there is a systolic blood pressure of less than 90 millimeter of mercury or requires vasopressors to maintain the blood pressure more than 90 millimeter of mercury, or if there is a sudden fall of the blood pressure by more than 40 millimeter mercury from the baseline value. These are the criteria to say hemodynamic instability in case of pulmonary embolism. If you suspect pulmonary embolism, but patient is hemodynamically stable, in that condition, do the D-dimer. If the probability according to the clinical score is low or intermediate. If D-dimer is negative, it is not a pulmonary embolism. If D-dimer is positive, before moving to the treatment, go with the CT pulmonary angiography. If it is positive, it is a pulmonary embolism, treat it. If it is negative, it is not the pulmonary embolism. In the high risk cases, again, there is no need in the high probability cases, according to the clinical criteria, go directly with the CT pulmonary angiography and treat accordingly. Now, the patients who now you got the diagnosis of pulmonary embolism. Now, patient is hemodynamically unstable. What to do? So, if it is a high risk, means with the hemodynamic instability, go with the thrombolysis. Thrombolysis is class 1 indication if the patient is hemodynamically unstable with pulmonary embolism. If the patient is not fitting into the criteria of the high risk, it may be either intermediate risk or low risk. In the intermediate risk, if the troponin I is positive with RV dysfunction, this is an intermediate high risk and requires close monitoring, because such patient may collapse at any time and requires treatment as per the risk for the high risk pulmonary embolism. For the low risk cases, we can discharge patient on anticoagulation only. So what are the, so now you got the treatment. High risk case with hemodynamic instability, this is the only indication for the thrombolytic therapy. There is no other indication. There are few indications if the patients like putting on the anticoagulation, if they become unstable later on, then requires thrombolytic therapy. So recommendation for the anticoagulation in pulmonary embolism without cancer. The therapeutic anticoagulation for at least 3 months is recommended for all patients with the pulmonary embolism. Minimum 3-month therapy anticoagulation. Now, what are the conditions when we can discontinue anticoagulation after 3 months? For the patients who had first time pulmonary embolism or VT, secondary to the major transient or reversible risk factor. In that condition, if it is a reversible condition, that was the cause for the pulmonary embolism, you can stop anticoagulation after 3 months. So 3 months is necessary in all cases. Now, what are the conditions in which extension of the anticoagulation beyond 3 months is recommended? That is, patients who having recurrent VTE or pulmonary embolism, or the patients who having anti-phospholipid antibody syndrome. So basically in this condition, oral anticoagulation with vitamin K antagonist, that is the warfarin and acetrom. These are the only anticoagulation recommended in cases of anti-phospholipid antibody. There is no role of NOAC in anti-phospholipid antibody syndrome. So this is the only condition. Now, what are the other indications when we can continue anticoagulation beyond 3 months? So these are basically class 2A recommendation, basically depending upon the consensus on few trials, so that we can leave it. Now, what are the NOAC required in pulmonary embolism? These are the basically 3, rivaroxaban or apexaban. These are the 2 mostly researched molecules in pulmonary embolism that you can start immediately for the 3 months in the therapeutic dose, and after 3 months you can decrease the dose. Now, the patients with the cancer who develop pulmonary embolism, they require minimum 6 months of anticoagulation after acute pulmonary event. In the patient with the cancer, managing incidental pulmonary embolism in the same manner as other cases of pulmonary embolism. So there is no difference in the treatment. Only thing is that we have to continue anticoagulation for minimum 6 months in cancer patients. Now, pulmonary embolism in pregnancy. So formal diagnostic assessment is almost same as for the other cases of pulmonary embolism. D-dimer measurement and clinical prediction rules should be considered to rule out PE during pregnancy and postpartum. In pregnancy, we should prefer venous compression ultrasonography to look for the venous thrombus. Perfusion scintigraphy or CT pulmonary angiography should be considered to rule out suspected PE in pregnancy, but it is only class 2A, so should be avoided. Therapeutic fixed dose low molecular weight heparin, that is enoxaparin, based on the early pregnancy body weight, is recommended for the treatment of the pulmonary embolism. Thrombolysis and surgical embolectomy should be considered for the pregnant woman with high risk pulmonary embolism. Now, recommendation is for the treatment, it is not recommended to insert a spinal or epidural needle unless at least 24 hours has been passed after giving the last dose of the LMWH. And epidural catheter removal should not be done within 4 hours of the LMWH. This is the simplified PACE score to decide for the mortality risk in pulmonary embolism. If the risk is 0, if the point is 0, lower risk of the complication. If it is 1 or more than 1, high risk for the complication or death. Now, coming to the thrombolysis. What are the thrombolytic agents used in pulmonary embolism? Basically, there is only single drug, that is the alteplase, that is to be given 100 mg over 2 hours. This is the only indicated thrombolytic agents in pulmonary embolism treatment with hemodynamic instability. Though others thrombolytic agents are available, that is retiplase, tenecteplase, but these are not recommended. People are using thrombolysis with retiplase, tenecteplase, but it is not recommended. Only recommended is alteplase 200 mg over 2 hours, not over 24 hours or 12 hours. The greatest benefit is observed when the treatment is initiated within 48 hours of the onset of symptoms, but thrombolysis can be given up to 14 days from the date of the acute event. Contraindication we all know. Now, what are the indications for the catheter-directed therapy in pulmonary embolism? Basically, when there is a contraindication for systemic thrombolysis, we cannot go thrombolysis with the systemic agents or failure of the systemic thrombolysis. So what we are doing in this, we are putting a catheter in the pulmonary artery and giving the thrombolytic agent at the low dose. So basically bleeding risk is very less and success rate goes high. Catheter-directed technique, reperfusion technique are catheter-directed clot fragmentation. By putting the pictal catheter, we are moving it and basically breaking the thrombus into multiple small fragments. Aspiration embolectomy, rheolytic, local, and ultrasound accelerated catheter is a newer technique. Probably we can start soon here. So summarizing the pulmonary embolism, it is acute pulmonary embolism, the most serious clinical presentation, having a high mortality up to 15% in first month. Simplified PACE score determine the pulmonary embolism. In patient with the acute pulmonary embolism, anticoagulation is recommended, with NOAC should be the preferred option. The standard duration of the anticoagulation should cover at least 3 months. Extended anticoagulation beyond the first 3 months or even indefinitely may be necessary for secondary prevention after weighing the individual patient's risk of the recurrence or versus bleeding risk. Second, after 3 months of the treatment, we should send the patient for the ventilation perfusion mismatch if patients remain symptomatic to rule out chronic thromboembolic PAH. Thank you.
Thank you very much, Akajan sir, for a very nice presentation of thromboembolism. When we were going to the NABH inspection, we used to put in the files the well score. Nobody knew what the well score meant or the Caprini score meant. But from that day, when we used to put the well score as per the NABH protocol in the files, we were aware that prevention is better than cure. We always, when I ask my residents how much time the patient ICU mein, sir, 2 din. When I start look for the DVT, look for the profile axis, look for the exercises done for the patient for the prevention of the pulmonary embolism. That is more important, because treating and converting the patient to chronicity is more dangerous, because after pulmonary embolism, patient will have a PH. There's no doubt. Sir, you will agree with me. Sir, one problem which we faced just 2 days back or 3 days back, patient has landed into our hospital after a pulmonary embolism. You saw that. He had an operation of fracture neck femur. He was not, he was operated and he landed into collapse. He was having a pulmonary embolism, CTPA was done at Vedanta. But he was not thrombolized even at Vedanta. When he landed up, she had a PO2 of about 60 on room air. We didn't, because of the wound of incision, it was difficult to thrombolize the patient. And patient collapsed on the third day. Sir, what is the duration of the time from the day कि 48 घंटे में करना चाहिए, 7 दिन में भी कर सकते हैं, 14 दिन में भी कर सकते हैं, क्या इसका कोई कुछ है क्या सर?
As in the coronary cases, we have the golden hours of 1 hour. Means we have to thrombolize the patient within 1 hour. That's the best strategy. For the pulmonary embolism, early is the best is the strategy for the pulmonary embolism. But the best result we are getting once you are thrombolizing the patient within 48 hours of the embolism. But if it is because of some reason it can't be done, then we can go up to 14 days. But in the coronary, there is no need of the thrombolysis after 24 hours. It is going to damage rather than helping the patient. But in pulmonary embolism, you can go up to 14 days because the anatomical, there is a difference between the coronary and these pulmonaries. Yes.
Thank you very much, sir. Sir, now I will invite Pradeep Gupta, sir, professor and head of the department of cardiology SAMES, for his lecture on 2 important trials of 2020.
Thanks, Dr. Abbas, for nice introduction. And basically, I have kept this talk for PGs. So I would request all the PGs to move forward, please. I'm going to talk 2 important trials which were presented last year at European Society of Cardiology meeting, and they are clinically relevant because we face these problems in our day-to-day clinical practice. So let's start with the first case. And here is a 32-year-old lady came to me with the following echo report. Mitral valve was thickened, area was 0.9, gradient was 28/16, RBSP was 52, ejection fraction 60. The similar case was presented by Dr. Suesh. Only difference in that lady and this lady is she was in normal sinus rhythm and here lady is fibrillating, right? So the next question comes for PG. Should we anticoagulate this patient? Anybody would like to answer? Answer is certainly yes. She should be anticoagulated. The next question the PG should ask, why? Reason is that this lady is at 17-fold increased risk of a stroke than a lady who doesn't have mitral stenosis with atrial fibrillation. Simultaneously, if you compare the risk of a stroke in a non-valvular AF and a valvular AF, in valvular AF, there is a 3.5-fold increased risk of a stroke than a valvular AF. So that's the reason she should be anticoagulated. The next pertinent question is, what should be the choice of anticoagulant? Should we give rivaroxaban? Should we give warfarin? Should we give apixaban? Should we give factor 11A inhibitors? Any of them would you like to comment? Anyway, answer is warfarin. Now the next question, why warfarin? Why not rivaroxaban and apixaban, which doesn't require any monitoring of INR and it's much more convenient? And here comes the first trial which gave this answer. This was the Invictus trial in which the patients of rheumatic mitral stenosis with atrial fibrillation, the rivaroxaban was compared with warfarin. And this is the first randomized controlled trial in this cohort. And one arm, of course, got the rivaroxaban, another arm got the VKA, and the primary composite endpoint was of stroke, systemic embolism, MI, and death. And if you see here, Up to 18 months, both the Kaplan-Meier curves were superimposed. There was no difference. But at the end of the trial, there was a difference of almost 25%. VKA did better than rivaroxaban. There were more strokes, more deaths with rivaroxaban than VKA. Myocardial infarction was same. Of course, the death was more with rivaroxaban. Bleeding were same. So in the trial, the conclusion was that the VKAs should remain the standard of care in rheumatic heart disease with mitral stenosis and atrial fibrillation. Now let me look into the guidelines. And these are the European Society of Cardiology 2022 guidelines. And they clearly mention AF patients with the prosthetic mechanical heart valves and moderate to severe mitral stenosis should get VKA with keeping INR in the therapeutic range. So the take-home message from this trial is the current standard of care in rheumatic heart disease with AF, VKA should be continued. That's number one. But number two, we should be cautious of off-label use of NOx. A lot of cardiologists used to get rid of about AF. That should be avoided. That's and if only was moderate race and physicality and be E by prime 11.66, volume index 97, and pulmonary artery systolic pressure 38 PA. NT-proBNP was 760, and ECG showed normal sinus rhythm with LVH and LVSP. What's the diagnosis? Anybody? Diagnosis is heart failure with preserved ejection fraction. This diagnosis, heart failure, we write very commonly. But heart failure with preserved ejection fraction diagnosis is not written very frequently, and we should be able to write it more and more in future because the prevalence is almost the same as HFrEF. Now, the next important question is, which is the most important GDMT for this patient? Is it ARNI, which is a combination of sacubitril and valsartan? Is it carvedilol, or it's a dapagliflozin or aplerenone? PGs are familiar with the word GDMT. If they are not familiar, always remember guideline-directed medical therapy. And this word is very frequently used these days. So the answer is dapagliflozin. And this answer came, but before we move on to that, that's to explain you the phenotypes of the classification of heart failure on the basis of ejection fraction. So if the ejection fraction is less than 40, it's a HFrEF, that's a heart failure with reduced ejection fraction. If the ejection fraction is between 41 to 49, it's heart failure with mildly reduced ejection fraction, what we say HFmrEF. And 50 and beyond, it is HFpEF, right? They have included another phenotype. That's those patients of HFrEF who had initially ejection fraction less than 40. With GDMT, the ejection fraction has improved. And now this group is called heart failure with improved ejection fraction. So these are the four phenotypes on the basis of ejection fraction. So let's move on. This is the DELIVER trial in which patients of heart failure ranging ejection fraction from 41 to 75. So basically it included patients of HFmrEF and HFpEF. Were given dapagliflozin along with another arm placebo. And these are the results, the primary composite endpoint of worsening heart failure and CV death was significantly reduced by 18%. Worsening heart failure was significantly reduced by 21%, but there was no significant difference on CV death as well as all-cause mortality. Secondary endpoint, the symptom score was better, their quality of life has improved. So conclusion from this trial was that patients of HAF-MREF and HAF-PAF, dapagliflozin achieved the primary endpoint, irrespective whether the ejection fraction is 42 or ejection fraction is 75. Whether your BMI is 22 or BMI is 48. Whether your patient is hospitalized or your patient is ambulatory. So they concluded that these data provide further evidence to support the use of an SGLT2 inhibitor as a foundational therapy in patient with heart failure, regardless of ejection fraction. And these are the ACC/AHA 2022 guidelines of heart failure. And this is the first time in HAP-PAF any drug has been given a class 2A recommendation. In fact, that recommendation was on the basis of Emperor Preserved. After delivered, the trialist, they suggested now it should be recommended to class 1A, and it is likely to be revised in future. Another query comes with this: do we need an echo before starting SGLT2 inhibitors, or do we need LVF phenotypes of heart failure? Answer is because this drug is effective all across the spectrum of ejection fraction, you can order an echo, but don't wait for starting SGLT2 inhibitor. So ladies and gentlemen, I will finish off with this quote of Sir Richard Doll, that death is inevitable, but premature death is not. So utilize GDMT in all your heart failure patients, including SGLT2 inhibitors, improve their symptoms, quality of life, decrease their morbidity and mortality. Thanks for your kind attention, and thank you.
Thank you, sir, for such a beautiful message, particularly to all the postgraduate who are sitting out there who feel inhibited in starting any therapy. They wait for the consultant or to ask about the treatment. So in one lecture, we learned old is gold, VAC is continuing. In another, the new is making a mark. Thank you. The audience is open for any single or question, if anything, sir. Even I have Dr. Gaurav Singh can come very well for the concluding remark as well.
As you say, dapagliflozin is effective across all spectrum. So many times, even during my residency days, I got confused. Suppose I have a patient who has a history of recent ACS and his LV function is, suppose say 35 or 40. Right. But he's in NYHA class 1 and no symptoms of dyspnea, orthopnea, PND. Does it deserve SGLT2 inhibitor?
I think it's a very valid and important question. ACS patients whose ejection fraction is low, he is asymptomatic at this point of view. You have to evaluate the ejection fraction at 6 weeks, because after infarct, the LV remodeling is going on. As at 6 weeks, if the ejection fraction is low, certainly one qualifies for SGLT2 inhibitors, as other adverse cardiac remodeling drugs as ARNI, beta blocker, and MRAs. Thank you very much.
Thank you. I call upon Dr. Gaurav Singh for the concluding remarks and vote of thanks.
I would like to thank all dignitaries who are present here, and I would like to congratulate Dr. Pradeep Gupta sir for organizing such a wonderful meet. And I hope such educational events continues in the future. Thank you very much.
I would like you all to proceed for the lunch. Postgraduates are requested to go to the mess.